Thanks again, Dr. Gusani, for talking to us about the pancreas. Tell me about pancreatic cysts.
Oh, thanks, Chris. It's a pleasure to be with you today. It's the middle of November, and as you know, November is Pancreatic Cancer Awareness Month, and so I like to be dressed in purple and to be trying to raise awareness for these diseases. Pancreatic cysts are a much more common topic now than they ever were. We always knew that there were cysts that can arise in the pancreas, but now with modern cross-sectional imaging with CT scans and MRI that have excellent high definition, and patients are getting these tests much more often for any type of ailment they may have, we are finding cysts at an increasing rate, and in fact every week there are probably 4 or 5 patients in our clinic who are diagnosed incidentally with pancreatic cysts. So it's an important thing to know about.
And how do you tell a scary cyst from a benign cyst in imaging?
Great. So, that's the critical thing, is that not all pancreatic cysts are worrisome. Sometimes cysts are benign and have nothing dangerous about them, but there are cancerous or precancerous cysts, and it's really important to be able to differentiate those. We start with imaging, so most patients will get either an ultrasound or a CT scan. If they just get an ultrasound, we'll follow up with a CT scan or MRI that includes IV contrast if possible to help us get definitions of the cysts. And the things we're looking for are size, growth if we have 2 points in time to look at the cyst, symptoms, and the characteristics on imaging, so how the wall looks, whether it's thickened or whether it takes up the contrast, so it has a vascularity, and whether there are nodules in the wall. So we know that the cysts that turn into cancer, it often starts along the edges, along the wall, and we get mural nodules, so nodules in the wall that can be worrisome signs that make us think twice about whether that cyst is precancerous.
Okay, and how do endoscopic techniques aid in the workup of these patients?
Well, our colleagues in GI have revolutionized the care of pancreatic cysts, and it's critically important that we work together to diagnose these things. Often, worrisome cyst by imaging, we'll send the patient to our gastroenterology colleagues, and they can do an endoscopic ultrasound. So here the endoscope is placed either in the stomach or duodenum, and the echo part of the endoscope, or the ultrasound part of it, goes through the wall of the stomach or intestines and can look at the pancreas with very high definition. We can see the changes, we can see the walls of the cyst, we can look for blood vessels within the wall, and we can even target areas of the cyst for aspiration, for cytology, to look under the microscope for cancerous cells, and most important, we can take fluid out of the cyst, which can help us diagnose what's going on with that cyst and what type of cyst it is.
Mm-hmm. And so what's the management based on what kind of cyst it is?
Right. So I think there are probably about a dozen types of pancreatic cysts, but if we stick to the 4 major ones that are important, we can talk about mucinous cysts on one hand and non-mucinous cysts. The mucinous ones that have mucin in them or thicker fluid, those are the ones that are dangerous, Chris, and those are the ones that potentially have a malignant potential, and we can figure that out based on the characteristics of the fluid, sucking it out, and we actually measure a tumor marker within the fluid called CEA, which tells us whether it's mucinous or not. The other 2 types of cysts, the most common ones are a pseudocyst, which is actually a result from pancreatitis or inflammation of the pancreas, and these are usually benign, and a serous cyst, which is like a bunch of small cysts together. A cluster of grapes is what we call it on imaging, and these are completely benign, and once you can diagnose that, you can stop worrying about that cyst. And so with a combination of the fluid analysis, the CEA level, and the amylase is the enzymes that the pancreas makes, we can diagnose what type of cyst it is and then decide how closely it needs to be followed, or if it's worrisome enough, whether we need to remove it.
Mm-hmm. And how do you remove it?
So very carefully is the answer, but no, I think the pancreatic resection techniques have greatly improved, and we can remove a lot of these things minimally invasively. So most cysts are probably found in the tail or the back half of the pancreas, and we can remove that cyst by taking a piece of the back of the pancreas. We often have to take the lymph nodes around that area, as well as sometimes the spleen, and that operation can be done minimally invasively now. It's called a distal or a left pancreatectomy, and it's probably the most common operation for cysts in the tail of the pancreas. We can completely remove a cyst. If it's cancerous, of course, we're doing a cancer operation. Even if it's precancerous, we can remove the chance that it will degenerate into a cancer. For cysts on the other side of the pancreas, the head, the procedure is a little more complicated. It's a resection of both the head of the pancreas and the surrounding organs, called a Whipple procedure or pancreatic duodenectomy, but still can be done either partially or completely with minimal invasive means, and we can remove the chance of these cysts becoming cancerous.
Great. So it is a pretty big topic with a lot of ways we could go with it. But how about just some sort of summative comments about pancreatic cysts?
Yeah, I think the key is awareness. So unlike cysts, say, in the kidney or the liver, where most of them are benign, a lot of pancreatic cysts can be potentially bad actors, and so a finding of a pancreatic cyst should prompt a evaluation to sort of determine kind of the characteristics of the cyst by imaging, as we talked about. You need to talk to the patient and get a history of whether they've had pancreatitis or other conditions that can lead to cysts, and then sometimes we need to do further evaluation with this endoscopic ultrasound to get us the best data we can to figure out if this cyst is potentially cancerous now, which is thankfully rare, or precancerous, in which case it needs to be, we need to consider removal or very close follow-up.
Okay. And you mentioned a tumor marker in the mucin of one of the mucinous cysts.
Yeah.
Are there any other serum markers that are useful?
Right. So there is a serum blood tumor marker called CA19-9, which we use for pancreatic and biliary tumors. Thankfully, it's not elevated very often in people with cysts because they rarely actually have an active tumor. They usually have a precancerous cyst. And so it's not as helpful in patients with pancreatic cysts. With a worrisome enough cyst, I will check the CA19-9 to make sure, and if it is high, I worry that this cyst could be cancerous now. But usually we rely on the CEA level, so a different tumor marker within the cyst, which tells us if that cyst is mucinous or not and has a potential for malignancy.
Great. Last words for surgeons and surgeon learners?
Well, pancreatic cysts is an important topic, and we're finding them more and more often, and we have great minimally invasive means for characterizing and diagnosing these, and early referral to a pancreatic specialist is probably always a good bet.
Great. Thanks again, Dr. Gusani.
Thanks a lot, Chris. I appreciate it.
Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook, follow us on Twitter, and find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.